Thanks very much indeed, Nick, for the introduction and Mark for introducing the overall thing. So as Nick has said, he's told you a lot about the science, and that's of course the bedrock of really understanding these conditions. But what I thought I would do is I would just think a little bit more about some of the top research questions. So a while ago when I started looking into this, we did what was called a James Lind Alliance priority setting partnership to really try and ask what are the top research questions in this particular area. And these are really nice initiatives because they don't just ask gastroenterologists, they also go to surgeons, nurses, and really importantly, patients as well to get the top research questions in an area. So you can see that numbers 1 and 2 pretty much point to what Nick's just told you about, is trying to get the best treatment to the right patient at the right time and personalised therapy. But I'll just draw your attention to some of those other really important things that came in the top 10. It's other symptoms. It's like pain. It's like fatigue, as Nick mentioned. It's like those difficult perianal fistulas. It's like continence issues, worry about dashing to the toilet and the impact of that on life. And these were really important questions as well. So what I'm going to do in this talk is just focus on 3 particular areas that I've had interest in researching over the last period of time. It's thinking about clinical outcomes, that really difficult phenotype of perianal Crohn's disease. Thinking about better decision making in those patients at risk of colorectal cancer. How can we be smarter at actually surveying those patients? And then finally, just something which I feel very strongly about, holistic management of this patient group. So first of all, perianal Crohn's disease. Well, just a moment, this Friday lunchtime, a history lesson. So the hospital where I work, it's called St Mark's Hospital. It was founded around about 200 years ago, actually, by a chap called Frederick Salmon, and it had this rather catchy title. It was the infirmary for the relief of the poor afflicted with fistula and other disease of the rectum. And that was at a time in Victorian England where in the centre of London you would have your hospital for fistulas alongside your hospital maybe for the foot problem, or maybe Mark, your problem for pregnant people, or whatever it was. But this is how the hospitals actually worked in central London. Now, I don't know if anyone knows who the middle picture is, but let me tell you, this is a picture of Charles Dickens, who actually had a fistula himself, and he was operated on by the founder of our hospital, Frederick Salmon, successfully. And actually, Charles Dickens bequeathed one of his books, signed copy, to the hospital. The picture on the right is Alan Parks, who gave his name to a classification of fistulas. But just to see the picture of the hospital when it was in the centre of London, you can see hiding behind the trees there, St Mark's Hospital for Fistulas. So maybe coming from this hospital, it makes sense that I've taken an interest in this area of research. But of course, one of the biggest problems is we don't understand the mechanism. And Nick has beautifully talked about some of the factors involved. And you can see all of those sorts of factors on the right-hand side. It's something in the microbiology. It's something in the immune system. It's something in our genetics. But with fistulas, there are also some of these really important anatomical issues, which you can see on the other side of this picture. The fact it's physics of healing in a cylindrical shape, that makes it difficult. The fact you've got a high pressure zone there. And I think until we can really try and marry up some of these more surgical or anatomical features with some of those processes Nick has absolutely underlined, only then will we really make progress in this particular area. So what have we done to really try and think about some of these clinical outcomes? Well, my very good colleague Phil Tozer, who's a surgeon at St Mark's, and myself set up a few years ago now a consortium trying to look at treatment, optimization and classification of this difficult phenotype for Crohn's disease. So it's a group of like-minded clinicians from across the world who want to think more deeply about how we group patients or classify patients. What outcomes can we actually measure? Because of course that will lead us to better treatment pathways for the patients. And this has been a lovely endeavour actually, because it started with Phil and I literally in a joint clinic at St Mark's, trying to think through how a surgeon and a gastroenterologist could come together to really better outcomes. And it's now a group of over 80 people across the world. So when we think about our trials for Crohn's disease, of course, you've got to think about the PICO. That's the patients you put in, the intervention, the comparator, and the outcomes you're going to think about. And in this sort of Crohn's disease, we realised we really weren't doing very well with understanding those particular groups. So we've tried to break that down a bit and think, how can we better understand it? So just to start with, the novel classification of Crohn's disease, and this is what the group, that consortium of people I mentioned to you, has put together. And I don't want to go through this in detail, but it simply makes the point that those patients with perianal Crohn's, it's not one group. In fact, it's multiple groups. And again, to get the right patients into trials, we need to think about these groups in a better way. And we need to think about them in this different way to help Nick understand those groups to study more scientifically. So, for example, the class 1 patients, we need to know that group. Who are they? How does their disease behave? And maybe what trials they go into, and so on and so forth across the classification. And then you can think at the O of the PICO, we need to be smarter at thinking about the outcome measures for these patients. And again, when we looked at the literature, we found that it was really very muddled. Lots of different outcomes being measured in trials and no common language for it. So again, a group came together to do what's called a core outcome set. And it's a very robust set of analysis that goes into this. Again, a multidisciplinary group that comes together to think, what outcomes would we all think are the right ones to put into the trials that we're going to use to treat these patients? So that's what this group did, and that's what the outcome set that this group came up with looked like. It was a large piece of work. It spanned a year or two, actually, but this is the outcome measures it came out with. So importantly, patient-reported outcome measures, clinician-reported ones, and of course something objective, which for perianal Crohn's was imaging. Just again to give you a snapshot into, of course, an outcome needs to be measured. So all of those different outcomes need to have a measurement set, and that's the next raft of work that different fellows in our hospitals have actually been doing. And this is work that Sam Adegbola did a few years ago now, where he looked at the quality of life of patients with perianal Crohn's. And he's produced this very nice quality of life measure, which has now been validated and translated into different languages across the world, so that this sort of measure can be used in the trials that we're doing to help assess quality of life for patients in our clinics, of course, but also in the trial setting as well. And I mentioned these outcome measures need radiology as well. So a colleague in our hospital thought about this concept of measuring the volume of the fistula rather than just the actual image itself. And again, the group is thinking about how we would define maybe what an improved fistula is or what a healed fistula is. It's amazing, again, that you just need to have the same language so that you're measuring the same outcomes in trials across the world going forward. So I think that's just a little snapshot, top-level stuff in perianal Crohn's. So I think with that, those sorts of PICOs, this is the sort of clinical outcome work that we're doing. So the stage is very much set for big trials, with Nick underpinning it all. We're thinking about pathogenesis at that sort of level. What about this difficult area of colorectal cancer? So Nick said right at the get-go in that very first picture he showed you, these patients are at a higher risk of colorectal cancer. So how can we survey these patients better, and how can we help patients make difficult clinical decisions about when, for example, to have a colectomy, their colon removed? So again, if we look to our hospital has got the longest and largest surveillance cohort, and it spans at least 50 years now, actually. And again, this research fellow, Ryan Choi, some years ago, did a 40-year analysis of the surveillance program at St. Mark's. This formed really, again, the bedrock for a lot of the future research over the next 10, 15 years. And what he showed was certainly decade on decade, we're just picking up more of this early cancer, what's called dysplasia. And of course, our patients then want to know what to do with dysplasia. So if we find dysplasia in these patients, they say, okay, well, what is my risk of developing cancer? Maybe what is the chance there is already a cancer there and something's been missed? What are my personal options? What would the surgery involve? What would the ongoing surveillance involve? What would the drugs that you're trying to treat, or remember all those drugs Nick has mentioned to you, what would they do if dysplasia is there? And these are the questions we get asked by patients all the time when we're thinking about surveillance. Again, Ryan's work pointed to one very clear fact, and that was inflammation. As Nick has said, this is a key part of inflammatory bowel disease, and patients who just have a cumulative burden of inflammation, that did put them into this much higher risk group of getting cancer over time. So that certainly was a factor that sung out in the data. And then another fellow, an excellent fellow, Misha Kabir, went on to think, can we actually improve the advice at that individual patient level? So not population level, to help the patient in front of you. So what she did was a retrospective validated cohort study of patients with low-grade dysplasia and followed them until they came to cancer. And the factors, they might sound quite intuitive, but this work had to be done. It really boiled down to, is the lesion big? Can it be resected? Are there lots of spots of dysplasia, if you like, across the colon, i.e. is it multifocal? And exactly like Ryan's work, is there a lot of inflammation? And then what we wanted to do was make something that we could communicate this sort of concept with the patient in front of you. So if a patient's got dysplasia, you would simply go onto this particular tool that anyone can use. It's got a website you can see at the bottom there, and you would fill in the dots regarding some of the factors here. And then you can see in these sorts of paling charts, you can tell this patient, well, look, your risk of cancer after 1 year is whatever it is. After 5 years, it is whatever it is. To help patients very much see that tipping point of when they think, okay, now I'm not comfortable with this risk, and I'm thinking about, for example, surgery as the thing that I want to embark on. But can we do better than this? And of course, everyone listening knows the answer to that question is always yes, we can do better. And again, this comes back to the biology of the disease now and the need for improved understanding of this very difficult pathway now of inflammation to cancer. Because while we know quite a lot about sporadic cancer, colon cancer formation with this sequence, which has been well recognized, it is far less well understood the process which is involved in the inflammatory to cancer pathway. And actually, what Trevor Graham, who's a very good collaborator for at least the last 15 years, and I have thought about, is more thinking about clonal evolution and expansion, this concept which is temporally underlying the whole cancer process. Can we look at this to help us understand a bit more of the biology of this difficult pathway? Can we measure this? Well, I'm going to go into just a tiny bit of science here, top level science here. And the answer is yes, we can. We can use this technique called low pass shallow whole genome sequencing. And essentially what I'm showing you here is the chromosomes you can see on the x-axis. And essentially you can see a bar here. So for the red bar here, if you have a line below, that's a loss of copy number, and a line above on the blue, that's a gain in copy number. And this is a really good technique because you can use it on historic samples, so archived formalin embedded samples from our large surveillance cohort. You can put that on, it's robust, it's cheap, it's something that can potentially be brought into the NHS. So what another fellow, Ibrahim Al-Bakir, did was looked at a group of patients matched, some who did not progress to cancer over time and some who did progress. And you can see in those little endoscopic images there that the two lesions look quite similar. They look similar under the endoscope. They look actually similar with histology. So how can we tell the difference between these? Some are progressing and some aren't. Well, if you look at this technique of the low pass shallow whole genome sequencing, they look really different. There's a lot of noise on the bottom one, that's the progressors. Then if you look at the bigger sample, and again, this is looking at a much bigger group of patients now, the non-progressors on the top compared with the progressors, the P group on the bottom, again, you can see just by eye, this is clearly a difference between these two groups. So looking quite interesting as a biomarker to pull out the patients who are going to have more trouble in the future. So we've done this in a discovery data set of patients, and in the red bar at the top, these are the ones who are low risk, and you can see a hazard ratio of 13.5. So this does look quite interesting as a way to pull these apart. And then, of course, you need to validate the data, and we've gone on to validate the data with actually a higher hazards ratio. So I think this concept of this copy number alteration burden being higher in the progressors than the non-progressors, being a significant risk for colorectal cancer, and actually outperforming those clinical factors that I showed you that Misha had pulled out. So potentially, can this sort of thing now be fed in a bit like in other diseases like Barrett's esophagus to really help with decision making for patients? So just in the final couple of minutes now, again, something I feel very strongly about, because as Nick mentioned again right at the beginning, these patients with inflammation carry a high burden of psychological problems, psychosocial problems, because of the chronicity of what is innately a relapsing, remitting and unpredictable condition. So as Nick said, we need to be hitting that target of inflammation hard with the best drugs that we've got. And that is at the absolute heart of it. But we know that there are several problems. One being exactly as Nick said, that it is still, slightly depressingly, a reasonably small proportion of our patients who we can really hit that target of inflammation with and get them well healed under the endoscope or maybe the microscope. It's around about 30 or 40% of patients. And even if we do get the resolution of inflammation, we know that lurking underneath that, these patients, even with well-healed bowels, have got major problems. They've got a burden of fatigue, they still experience pain, they still worry about getting to the toilet on time, and there's a lot of anxiety and depression, I think, in what is innately a relapsing and remitting disease of unknown cause. So in the final few moments, I'll tell you about the IBD Boost programme. And again, maybe just to tell you briefly the story behind this. So a very good nurse colleague, Chris Norton, and myself wrote a grant well over 10 years ago. We didn't get the grant the first time. We thought it was important, so we reapplied again. We didn't get it a second time, but we got a bit closer. But the third time we did get the grant. And it was a 5-year grant where we wanted to do a survey to look at the burden of these symptoms. Then try and just get the basics right in the optimised study. And then at the end, do a large randomised controlled trial looking at how we can maybe address these chronic symptoms in these patients. So again, just to give you the top level data, the survey was large. It was nearly 9,000 patients. 50% reported incontinence, 25% fatigue, 20% pain, and that was in the last week of these surveyed patients. And patients really couldn't untangle the symptoms. They described these vicious circles or cycles of symptoms. And also these psychological morbidities, depression, anxiety, were way underdiagnosed. 50% reporting depression, anxiety, but only 25% had known diagnosed mental health disorder, showing a big gap with what we're not really picking up. The middle study, again, this was run by our nurses, a very clear algorithm checklist, just making sure, again, we're doing the basics right. Are we picking up anemia? Are we addressing that? Are we treating that properly? And then finally, this randomized controlled trial. So this actually is the largest randomized controlled trial of a psychological intervention ever done in IBD. So it's in 780 patients. These were IBD patients, 18 years and over, and they were essentially randomized this boost intervention. And this was an intervention which was designed over a long period of time with a group of psychologists, nurses, doctors, and again with a lot of patient input. It went through a very hard MRC framework for complex disease interventions to make sure this intervention was as robust as possible. What it boiled down to was about 12 sessions over a 6-month period of cognitive behavioral type therapy. Initially, the basic principles of that, and then if the patient mainly had fatigue, the last 4 sessions would be bespoke to that. If urgency was the problem, bespoke to that, and so on. These are the patients who went into the study, and you can see slightly more Crohn's than you see, slightly more women than men, quite a lot with IBS type symptoms, and the vast majority in remission. This is the results from it. So actually the primary outcome measure, which was a disease-specific quality of life, the UK IBD-Q, you can see that there was no significant difference in the primary outcome between those who had care as usual compared with this intervention. So we were slightly upset, actually, that this didn't hit the primary outcome. However, when you look at the different measures we looked at, incontinence did improve in this group, both at 6 months and 12 months, and the EQ5D also did improve. But maybe most importantly, if we again looked at subgroups, these were pre-specified subgroups. It was the patients with IBS type symptoms in the IBD cohort who did well. And again, as a clinician treating a lot of these patients, I think we all know that that is the group who do particularly well with this sort of extra intervention. And furthermore, if we looked at a particular analysis, and I won't go into the statistical details of it, but it's called a case analysis. And essentially that points to the patients who were able to comply with the therapy. And I think for psychological intervention, patients have got to comply with something. And again, the patients who complied did well. So just to give a shout out to the IBD Boost team, this is a big group again across particularly London. We're called the Boosters. It didn't reach the primary outcome measure, but in the IBS IBD patients it did, and if patients complied, it did. And this is a strategy we hope is going to get a CE mark, and hopefully will be rolled out as something that we can all actually use within our clinical practice. So finally, Mark, before I hand back to you, I do like this quote from Hippocrates. Of course, I'm interested in the disease, as is Nick, but I am more interested in the person that has the disease than the disease a person has. So thanks very much to all colleagues, collaborators, research fellows, and of course the patients. Thanks very much.